All right, welcome everyone to the Wednesday, September 6th meeting of the Arizona State Board of Pharmacy's Controlled Substance Prescription Monitoring Task Force. The time is 9 o'clock and I'll call the meeting to order. Dr. Gandhi, I'm not sure if you're taking roll call or Mr. Scrivarles.
I'll redirect that to Sam.
I got it, Sam. Ms. Walmsley,
Present.
Amanda Sheenson.
Present. Scheinson. Thank you.
Thank you. April Romero. Dr. Lisa Villarreal. Stephen Borowski, I know is not going to be able to attend. Dr. William Thompson.
Hi there. Can you hear me okay?
We got you. Thank you, sir.
Great.
Josephine Zamudo.
I'm here, thank you.
Justin Bohal.
Present.
Kelly Fine.
Here.
Lynette Wingert. Margaret Whalen, I know is not going to be able to attend. Matthew Williams.
Present.
Melissa Cotrice. Michelle Almer. Pat McSorley.
I'm here, thank you.
Sarah Steffen.
I'm here, thank you.
Susie Berman. And Vicky Bukta. I see Melissa just joined. Hi, Melissa.
Hello.
Is Vicky here? Sam, how many do we got? We have 10, so we do have a quorum. So I think we can get started, and I'll pass the baton back to you, Lori.
Thank you. Does anyone have any conflicts of interest they'd like to disclose for the record before we jump into the first agenda item? All right, hearing none, I think first up is the presentation by our Access, the speaker from Access and Honor Health. Is that correct?
That's perfect. So we can turn it over to Dr. Salek and Dr. Norquist.
Sounds great. Really appreciate it. Thanks so much for having Dr. Norquist and I. And really, we're here to support the Board of Pharmacy in regards to their pursuit of removing the real and perceived statutory barrier for hospitals, including our emergency departments, to provide Narcan to individuals who are at risk of or have presented status post-opioid overdose. So specifically, the Title 36, 2608, as far as reporting requirements, it not only does the statute require reporting of controlled substances, but also of non-controlled substances, specifically naloxone. So with that, I have forwarded my presentation just to kind of give a little bit of overview of why this is so critically important at this juncture. And so I don't know if I do see you're going to start screen sharing, so I'll give it a second.
Dr. Salek, when you need a slide moved, just feel free. Lynn is working the computer and he'll advance slides as you need it.
Awesome. Thank you so much. Appreciate it. All right. So we can go ahead and move on to the next slide. So I did want to just give a 30,000-foot overview around why this issue is so critically important from a public health perspective. And I work closely with Department of Health Services, including Sheila Scholander, as well as Dr. Villarreal, who I know is part of this meeting. And, we monitor not only the data from, the statewide perspective, but also what CDC is monitoring in the trending. So this first graphic is from the CDC. And really, if I had to say, 3 things that this graphic is showing us around this 12-month ending provisional number of overdose deaths is around specifically opioid related deaths. And that's the black line specifically, but more critically important is that brown line, which is fentanyl, pretty much, because it's synthetic opioids minus methadone. And so we know, based off of what CDC is reporting, as well as our own data internally, that fentanyl is accounting for the vast majority of opioid related overdose. And unfortunately, alongside that gray line, we're also seeing methamphetamine. And so fentanyl, methamphetamine, and the other thing, as far as 3 words to describe this slide, is around the COVID pandemic, because you see that 12-month ending really starting to tick up, starting right around the pandemic. And so we know this is a critical public health issue in regards to over 5 Arizonans dying a day from opioid-related overdose. And in instances, it also includes psychostimulants, specifically methamphetamine is our primary concern. Next slide. And so, where we were concerned multiple years ago, and of course, we've got the CSPMP, and we're really working closely with the Board of Pharmacy, Department of Health Services around looking at, our overdose related events, both fatal and non-fatal. Are we seeing it related to continued prescribing, or has it shifted? And we really do feel like we've turned the tide in regards to prescriptions being dispensed by pharmacies. And so this graphic, which is the data source is the CSPMP, is really helping tell that picture. Next slide. And so, as I mentioned before, we are tragically losing 5 Arizonans a day to this opioid epidemic, which has worsened during the COVID pandemic. We are cautiously optimistic that we're seeing some decrease, or at least some leveling of opioid-related overdose deaths in Arizona, but 1 is too many, and so we still have a lot of work to do. Also wanted to note that we do have about 9 Arizonans a day who are overdosing, but non-fatal. And part of that solution, as far as it being non-fatal, is having Narcan in the hands of Arizonans. Next slide. All right. And so, as I mentioned before, Department of Health Services, based on our Arizona Vital Stats, is cautiously optimistic that we're not continuing to see an upward trend of opioid-related deaths, and it may be leveling off, but we still have a lot of work to do in order to reverse really the devastating impact of the COVID pandemic on the opioid epidemic. That, coupled with really a huge illicit fentanyl supply within the illicit marketplace. Next slide. So, what do we do about it? So we know that there are evidence-based interventions, including access to medication-assisted treatment, which, as the single state agency on substance use, we're continuing to work on improving access to good quality providers and getting rid of the bad actors that have come into the state as far as the substance use related fraud, waste, and abuse. So we're actively working on that. I think our primary really call to action at the Board of Pharmacy meeting today is related to the specific statutory real and perceived barrier that the Board of Pharmacy is in support of overcoming related to Narcan reporting to the CSPMP. So we can go ahead and go to the next slide. And so we do have, I wanted to note, in addition to naloxone being dispensed through our Arizona pharmacies, we are also supporting through our SAMHSA, which is the Substance Abuse Mental Health Services Administration grants, both our state opioid response grant as well as our state substance block grant, that we are able to support Department of Health Services in purchasing Narcan, including the nasal Narcan, and our hospitals and EDs can actually order that at no cost as far as the naloxone through that program. We're also helping support Sonoran Prevention Works through our community-based naloxone distribution. And so we continue these efforts in addition to that pharmacy prescription dispensing, because we know many individuals who are at risk of overdose, including their family and friends, may not choose to go to a pharmacy to fill naloxone. Next slide. And so this is actually demonstrating that we have seen, this is the CSPMP data related to naloxone. We have seen an increase in naloxone dispensing at pharmacies, which is a good thing. But we know that this is in concert as far as the naloxone dispensing from pharmacies. It's in combination with those other efforts I just mentioned. Next slide. All right, so why are we really targeting from an access perspective our hospitals and EDs? It's because they're a primary entry point for individuals who have opioid related overdoses or who are at risk of opioid overdose. And we have looked at the data along with Dr. Runger and his team to see for the DHS discharge data, which hospitals are disproportionately impacted by individuals who have overdosed secondary to opioids. And so they're a critical partner in regards to making sure they have programs in place, including naloxone programs to give individuals the actual physical drug as they're being either discharged from the emergency room or they're being discharged from the hospital floor. Because we know, based on evaluating the data, including both in Arizona and nationally, that many individuals, when they're provided a prescription, including an e-prescription to their local pharmacy, aren't actually picking up the naloxone just based off of the opioid disease process itself. So it's really important to get them education as well as the drug itself as they're exiting the hospital ED setting. Next slide. All right, so what is Access doing to help support, be part of the solution around assisting our hospital and ED partners to actually conduct naloxone programs, meaning educating individuals that are at risk of overdose who have presented with primary overdose of opioids, not only Narcan, but also education around how to prevent future overdoses. We have a differential adjusted payment, which is basically a financial incentives for our hospitals to adopt this type of program. Next slide. And so we do have specific policy standards related to if hospitals, including our emergency departments, sign up for our differential adjusted payment, that these are the components of their programs, which include patient screening and identification as far as those at risk of opioid overdose. Making sure they have naloxone in hand and connection to care when they leave the hospital, whether that be with a primary care practitioner or a substance use provider, making sure staff are educated for the evaluating the signs and symptoms. And part of that is stigma reduction around opioid related issues. And so really normalizing and making this as part of the fabric system, since they're really here to help support the public health of our community. And then we can go ahead and move to the next slide. These are our emergency departments that have signed up to participate in our differential adjusted payment for this upcoming federal fiscal year, which starts on 10/1. This is the first year that we're having our differential adjusted payment to incentivize these naloxone programs. And we have continued to hear from some of our hospital systems just this concern around the CSPMP reporting requirements. And so very much those hospitals are in support of the Board of Pharmacy moving forward and addressing the real and perceived barrier associated with the statutory framework to report naloxone to the CSPMP. So that's the next slide, which is our Arizona revised statute referencing naloxone. So really the one that we're talking about here is 2608, where it includes naloxone, even though it's a non-controlled substance, it includes naloxone reporting. So with that, I'm going to turn it over to my colleague, Dr. Norquist, who is an emergency physician and boots on the ground and has been a huge advocate for saving lives for many years and making sure that we get Narcan in the hands of individuals leaving our hospital. So Dr. Norquist, very happy to hand it over to you.
Thank you very much, Dr. Salick. So I don't have any slides prepared because I probably would have used the very same slides that Dr. Salick did. There's just so much in there that I think we all understand and we all want to do something about, and we actually have been doing something about, as demonstrated by the decrease in prescribing. We anticipated an increase in heroin use, but I guess what we didn't see coming was the amount of fentanyl, and we need to do something about that. And I think that this is a very important piece in helping our citizens, our patients, our friends, our families actually cope with that. As Dr. Salick also mentioned, over 60% of those people who had an overdose that did not die from it were witnessed by a bystander. We need to get the naloxone in the hands of people, and we need to get it in a significant amount because of the strength of fentanyl. I'm not going to preach to the choir. I think everybody on this call understands all of that. The stigma is another part that I think by having a take-home naloxone program or a naloxone distribution program, semantics, distribution, dispensing, I'll call it whatever you guys tell me to call it, as long as we can do it. But as an emergency physician, emergency nurses, there is a feeling by patients like that's the last place they want to go because they've been treated so poorly in the past. When we used to think that they were here to dupe us out of pain medications, that doesn't happen anymore because how ubiquitous fentanyl is and how cheap fentanyl is. No longer does somebody sit for hours in the emergency department and try to get a prescription out of me for a migraine or back pain or something so that they could abuse that medication, because they can spend their time differently and they can get that medication, they get fentanyl illicitly on the street for far cheaper. But what we can do by handing them medication instead of giving them a prescription is start to break down that barrier between the caregiver and the patient who actually needs help. We can start to chip away at years of that kind of dichotomy between the us and them, and we can start to actually re-invite them back to try to feel like we can give them that care. I liken it to the way that I've actually matured in caring for patients who have an alcohol abuse problem. In that, you first need to recognize that they are not going to seek help until they're ready. The same thing needs to happen with people who have an opioid use disorder or who have fentanyl issues, in that we need to do everything we can to keep them alive until they realize that they need help. Then we can start with medications like buprenorphine, methadone, other medication assisted treatment. But the important part is we need to keep them alive. And having Narcan to give to a patient to take home is so much more impactful and effective than giving them a prescription. In fact, at Honor Health, as soon as the mandate came out about 2017, 2018, we just started printing a naloxone prescription. We printed the standing order, and then we automatically e-prescribed a prescription as well. So we were kind of double prescribing naloxone, realizing that if anybody filled it, that's better than nobody. And that actually took some cultural change for our doctors to get comfortable with. Now they're actually kind of upset when it doesn't happen. So that's a good thing. So I think we're making progress. We also started that with a 90 MED And our doctor said, you know what, I really want that to be 50. So kudos to the docs at Honor Health because they really want to try to get in front of this. Having the Narcan is to give to patients has not been an easy venture. I had to go to multiple different areas in the hospital, including our legal, risk, regulatory, nursing, everybody, and try to get buy-in. And everybody had multiple different little reasons. No one had one major reason to not do it. Nobody would say, we just don't want to do this. It was always a series or a combination of little things, none of which in and of themselves was enough to end the program. But some of them were enough to just make you not want to have to push through. And I think the last piece, as Dr. Salek mentioned, that if we can remove would make this so much easier is that reporting part. We're currently having to avoid our pharmacy so that we don't run into dispensing issues. But our pharmacists and our pharmacy is the place that's best set up to report all of those things that are required for reporting of naloxone. So here we're being asked to not use our pharmacy, but then to do things that pharmacy is set up to do, which is kind of frustrating. And actually is that one thing that is preventing us from spreading this throughout the hospital. I've had obstetricians ask me for Narcan to have in our OB triage, only then to be essentially resisted or shot down by the leadership of OB because of the reporting requirement. And they don't want to have to go through and make sure that they're reporting all of those necessary details for every time that they give out Narcan. So if we can have that removed, I think we would have a far greater ability to provide impact to our patients. The distribution of Narcan, I think, is so important that I'm willing right now. What we're doing is we're tracking every dispense that we get in anticipation of having to track that just in case there was a recall of the medication. And then we could call that patient, say, you need to throw that away and we'll get you a new dose. But if we are mandated to have to report, either myself or I'm going to have to pay somebody to go through each one of those distribution, I'm using my words carefully, of Narcan and fill out those 20 to 30 different required fields of each patient. And that's going to be a very ominous and a very difficult task for us to do. So I'm pleading to have you guys remove that so that we can have this just take off here at Honor Health, but more importantly, elsewhere in the state. Dr. Salek and Dr. Villarreal, we had a conference 3 weeks ago, trying to get more hospitals to participate in this. Fortunately, there was a pretty good showing, but they were all the hospitals who'd already been doing it and already signed up. I think there's still some hesitation, some resistance from places until we remove these last pieces. And then I think what we'll see is everybody wants to participate in this so that we can start to get Narcan into the hands of everybody. And it being over the counter certainly helps from the regulatory perspective. But I think what we're faced with all the time is that it's still relatively expensive, especially for somebody who has a use disorder. They're not going to spend the $40 to $50 for over-the-counter Narcan. But if we can hand them that, or we can hand the mother of a teenager that to have in the household, we're going to start to have it become an ordinary type of thing to be in a medicine cabinet, similar to an EpiPen, similar to what Epicac was back in the old days when we used to try to get kids to throw up after they ingested something. I think that we've got good momentum here, and I think that we can continue to push. And I think if we can remove the mandatory requirement part, I think it's gonna take off, and we're gonna really start to see an impact.
Yes, and so we're happy to take any questions, but I think we're here to support the Board of Pharmacy. And I've talked with the governor's office as well, and they're very much in support of this as far as the 2608 CSPMP reporting requirements specific to naloxone, that's currently being perceived as a barrier for some of our hospitals to participate in the naloxone programs. And so I know thanks to Cam's leadership, as well as Doug's, that they're also very much in support. So I'll turn it over to Doug and Cam to see if there's anything else that you wanted to add or any questions from the group.
Thank you both for presenting about what the hospitals are dealing with, the state of the state. Dr. Salick, that was a great presentation. But when we talk about naloxone, what I want to just hit on first is the reporting requirement. And, we often hear that something's a burden. This truly is a burden to hospitals trying to get naloxone out easily and quickly to patients that would benefit from it. When you think about a PMP submission, there's like 45 fields that of data that need to be there, and if all those fields aren't filled out correctly, that submission errors out. Basically meaning as long as there's a reporting requirement, pharmacies are the most equipped to be able to report that data, and yet pharmacies can't just hand out prescription only meds without a prescription. So that's why Dr. Norquist has leveraged the prescribers in the ER to pass it out, keeping pharmacy out of it. Now everything's evolving, and Dr. Norquist hit on the fact that the OTC naloxone should be out any day now, and that's going to help. It's going to help because when naloxone if it's OTC, we just sell it, right? We in the world of pharmacy, the retail pharmacy just sells it like Advil. I think what we want is, Dr. Norquist also hit on the fact that it's not going to be cheap. And there's going to be patients that are going to want the pharmacist to try to run that through access as well as commercial insurances. So OTC naloxone doesn't solve everything, is my point. So for those that are thinking, why are we going after this statutory change whenever it's going over the counter? That's the answer. It may help. OTC naloxone may help hospitals get it out easier, but what about the pharmacies too? What about the retail pharmacies? If it's cheap, it probably isn't going to just be, if it's not cheap, it's probably not going to be sitting out on the shelf. I envision pharmacies potentially having it behind the counter, concerned about that. I don't know, but my point would be, if we want naloxone to be the cheapest possible for a patient, we have to be prepared for pharmacists to potentially bill the prescription to insurance. And as soon as they process it like a prescription, we're going to, the law says that you have to report that to the PMP. So removing that barrier makes incredible sense to me. Why I really wanted Dr. Salick and Dr. Norquist here was so that our task force could hear this burden that they're experiencing. I also want us to potentially rally around a bill if that's what it takes. And that seems to be the way that we would need this law to be changed. I know both Kim and Dr. Salick's been in conversation with the governor's office, but as we get to next legislative session, we need to be ready to run a bill and collectively get behind that bill, and let's get the naloxone out on the street.
Doug, can I just ask?
Yeah.
So yes, we're asked to do many things, right? The burden, there's many different things. We're all busy. We've all got tasks that have to be done. And if there was a very good reason to do this, if we were tracking where naloxone was so that other citizens could access it or something, I think it would still be a burden. It would still be a barrier, but at least we'd have a reason. And I don't think we fully understand the reason for the reporting. Like, is the purpose to have a map of where Narcan has been distributed? But if we're giving it to individuals, then it's going to be moving. So I'm just not clear of the purpose of the reporting. And I think that if we were to hear that there's, you know, an incredibly good reason to do it, then we might be able to get better buy-in. It would still be a burden, but it would. But I still am not really sure why we're being asked to report.
Yeah, and Dr. Norquist, the history of that was in 2017 during the state of emergency regarding opioids declared by Governor Ducey. Part of the desire was to track how much naloxone is getting out there, and we saw that through what Dr. Salek showed. But did that one graph change? Like that was the purpose. That graph that Dr. Salek just showed, and that was meaningful back then in 2017. Today, when we have it readily available and we want to get it out on the street and you can actually get it in a library, why should we have this burden for pharmacy and the emergency rooms? You know, it just doesn't make sense, right? So that's the history behind it, and I think that it had a purpose at that point, and my 2 cents is that it doesn't really have a purpose today.
Yeah, I couldn't agree more. And we really very much appreciate the Board of Pharmacy's leadership on this issue.
So the last thing I'd like to do is open it up for any questions to our task force members. And then I'd like to get a vote of, does the task force members believe that this is a meaningful bill for the Board of Pharmacy to run? And do we have the support of the task force? So first, I'm opening it for questions.
Hi, Doug. This is Melissa Cochise. I don't have a question, but just a comment. I'm really encouraged by the presentation. As an aside, I am participating in the Flynn Brown Civic Leadership Program, and my small group of colleagues there, in terms of working on a legislative proposal, specifically were interested to work on making this legislative adjustment. So as an aside, I would love to follow up with you, Dr. Salek and Dr. Norquist, because if we can include someone from law enforcement side, from public health, and myself, and maybe others. So if there's other efforts that we can do to support and advance legislation, both in our capacity in that program and in our individual capacities, we'd be really interested to do that. So I'm very supportive and appreciate the presentation.
Thank you so much. Well, then I think if we could just move to, do I have any objections from the task force members on us pursuing legislative change?
Doug, this is Lori. If you need an official motion, I'll make a motion to support the Board of Pharmacy's initial recommendation, which is to pursue legislation to repeal the requirement under 362608.
Second.
And Ms. Wamsley, just for discussion, there may be other sections, so that's, you know, I would probably make it a little bit broader and saying any other statute that may involve
Conflict.
naloxone.
Yeah, makes sense to me.
So we have a first and we have a second. Can I get all in favor? Say aye, please.
Aye.
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 Aye. Aye.
Aye.
Any opposed? Awesome. I think what this really does for us is legislation gets introduced, we can look at legislators and say, we have representatives of so many different organizations and associations, and hopefully that makes this a seamless transition. So as we get to legislative session, be on the lookout for communication from us, and be ready to support that, okay? All right, Dr. Salick, Dr. Norquist, you're free to go. Thank you so much for your time.
Thank you for
You're
having us.
Thank you very much.
All righty. I think from a housekeeping standpoint, we had a few others that joined the meeting. You know, I wanna make sure that I get roll correct. And April Romero, did you join the meeting?
Yes, I'm here.
Thank you. And Dr. Villarreal?
I'm here. Thank you.
Thank you. And Michelle Almer?
Sorry to be tardy.
And Susie Berman?
I'm here.
Thank you, Susie. And Lynette Wingert. Okay, she may not have joined. Okay, thank you guys. I'm going to jump into our next item on our agenda. And that's a discussion about xylazine a little bit. The DEA and the FDA have alerted healthcare professionals to be cautious of possible xylazine inclusion in fentanyl, heroin, and other illicit drugs. And the effects of xylazine they're not reversible through the administration of naloxone. And what we're seeing in certain parts of the country is this cross-contamination of fentanyl with xylazine. And xylazine is not safe for humans. It's a veterinarian-only medication. It's currently not categorized as a controlled substance by the DEA. On the street, it's often referred to as tranq and the zombie drug. And when injected, it's creating skin infections that are really gruesome. So some states have already categorized it as a scheduled medication within that state through legislation, lawmakers, governors, and in Arizona, the Board of Pharmacy has the ability to make a drug a controlled substance. And Kim has spoken to our board members, including Ms. Walmsley, and they supported Kim pursuing making xylazine a controlled substance in Arizona. It's a process. It has to go through a rule writing process, and then that'll have to be opened up to public comment and GERC. And, you know, best case scenario, that probably would be completed in the ballpark of late spring to summertime of 2024. We're not sure how long it might take the DEA to actually get it scheduled. So we wanted to be proactive and go after that scheduling of that medication within Arizona. Kim has spent some time with the Veterinarian Association and the Veterinarian Board and has not been met with any resistance with that. I've heard mixed results, mixed feelings about xylazine in Arizona. Some are suggesting that it really hasn't reached Arizona much. Others are saying that it is here. Either way, we know how this game goes. We know that it's going to get to Arizona. It's part of the illicit drug scene, and it will be here at some point, whether it's here in a sizable manner today or not. It will reach our state, just like all these drugs do. So I just wanted to give you a quick update about that and know that that's kind of on the horizon here. Cam, do you have anything else you'd like to share on that?
Thank you, Doug. No, you hit the nail on the head. This is a drug of concern. There's a lot of activity happening on the east side of the country. I think even Florida made a more aggressive approach and scheduled it Category 1, if I'm not mistaken. But the roadmap seems to be similar to how opioid moved across the country, starting off to the east and then moving to the west. And though we haven't heard a lot of rumbling here in this state, it'd be nice to be proactive and try to get ahead of the game. Otherwise, we'd be traveling the same road that we did with the opioid epidemic problem. I'm also working with law enforcement, not only to get it into the Board of Pharmacies statutes and rules, but also Title 13, so that it can be a criminal offense to distribute this medication without proper authorization. So there's some efforts behind this, and we'll keep you posted.
Do you guys have any questions about our efforts or xylazine in particular? I have a quiet crowd today. Very good. That was really just meant to be informative for everyone. And if there's no questions or anything you'd like to add, we'll just move on.
The pre-reading material was very informative. Thank you for that.
That's kind of you to say. We tried our best to give you the outline of what we talk about. So thank you. Well, the next item that I wanted to hit on is during last legislative session, we were able to get the right access to PMP data for overdose fatality review teams in Arizona. So that's been a couple years in the making. Through the partnerships with Department of Health, we worked to work it into language. In the past, what we used to be able to do is furnish this data to the Department of Health, but Department of Health can't distribute any PMP data. So what we wanted to do is get this into the hands of the local departments of health. They're the boots on the ground doing the work. This past legislative session, we were able to accomplish that. And for those that don't know much about overdose fatality review teams, where PMP data is going to be really helpful to them is around like the investigation and evaluation of the overdose. It basically means what led up to a patient overdosing, and often the PMP is your best thing to look back on, the PMP report for a patient, and you can see that maybe 3 years ago they started on an opioid, and then their opioid use increased over time, and then that eventually led to potentially illicit drug use. And in today's world, it seems like 80% of those passing away with an overdose seem to have fentanyl in their system. So additionally, some other benefits is identifying high-risk individuals, evidence-based timely policy development. And I think that's what you're seeing here. We're talking about policy adjustments around naloxone because of the work that overdose fatality review teams do. They point the finger at what trends are happening. And Dr. Villarreal, I don't know if you have anything you'd like to share. I know Department of Health works hand in hand with these guys. Is there anything I missed about the benefits of overdose fatality review teams?
No, that was great. I mean, I think this particular overdose, I mean, there are several here in the state that the Department of Health participates in. I think the Opioid Fatality Review Board is one of our newer ones. And so we're looking forward to continuing to grow and make that an increasingly powerful group. Thanks.
Thank you so much. So there's nothing that we need to take action on. This already has occurred, but I just wanted the task force to know that. Making PMP data available in meaningful ways has to be a focus. You know, that when PMPs were started, that the idea is you have to guard the data at all costs, and we still do. I have to protect the data based on what our laws say, but we changed the law to give that data to the right people to do meaningful work. And that's what I wanted to shout out there. Any questions about overdose fatality review teams? Okay. Well, I'm moving along pretty good. Maybe I'll let you guys out early today. The next item is about fraud notifications. So this is something that, you know, has been asked over and over again. Doug, can you send something out through the PMP? You know, it may not be perfect, but it's better than nothing. And I have to be careful to not clutter the PMP with a bunch of announcements. And you know, the most important thing about the PMP is let's get our doctors and our pharmacists to be able to use this and make meaningful healthcare decisions. That's the most important thing. But sometimes what we run into is a prescriber saying that their DEA number was stolen. A licensing board saying we have a prescriber that's still writing for controlled substances and they don't have a license anymore. So how can you let the pharmacist know to not fill this? Well, that's incredible. That's a challenge, but things like that, those are meaningful things for me to put into the PMP as an announcement. And it will pop up as soon as a provider logs into the PMP, they can see the announcement and hopefully pay attention to the announcment and react to it. It's far from perfect, guys, but it's something. It's better than nothing. I often get asked by a third party, can you just put it in for the doctor, for the licensing board? I need it. If somebody wants communication going into the CSPMP, I am going to quote that person. And it could be the licensing board, it could be the prescriber themselves that wants a certain message delivered. But I'm not going to take that from a third party intermediary. And that could be a pharmacist, it could be a staff member. I need to hear it from them and I'm going to quote them. I'm going to make them write it exactly like they want it. And you know, the background on something like that would be a prescriber says, please put into the PMP, do not ever fill a prescription for prometh with codeine from me. And then, you know, the issue goes away and 6 months later, the prescriber writes for prometh with codeine and a pharmacist has this up on their board and says, I'm not going to fill it. And now the pharmacist is in his tug of war with a prescriber. So I want you guys to know that I am doing my best to put the meaningful information in the PMP and get it out to the right people. But the only way I'm going to do it is from the prescriber themselves, or if a licensing board has something that they want me to put out there. So I'll pause there, see if you guys have any questions about that. In the packet,
Doug, this is Pat McSoy. I do have a question.
sure.
When the physician or when the pharmacist is checking the CSPMP and physician no longer holds a license, will that not show on whatever they're looking at that, there's no license in Arizona? Is there any way that information, I mean, when we revoke somebody or they no longer have a license, it's on our public facing website.
So, to get access to the PMP, you have to have a active DEA number and you have to have an active license. We verify that manually behind the scenes when a prescriber wants access to the PMP. But a lot happens in between, right? Prescribers can lose their license. They could lose their DEA license. They could forget to renew on time. What you're asking is something that I really want to go after. And I'd like to integrate the PMP with the software for the licensing boards. Because if I could integrate those two, I have a real-time answer. Because you would deactivate somebody within your own licensing board, or make their status, whatever your terminology is, closed or on probation or whatever. But if we could integrate with licensing boards, we would have real-time information that you're kind of presenting to me, Pat.
Yeah. I guess what I'm saying is if you went right into the AMB website, you put the license number in, you would be able to immediately see that the license was revoked. I guess and I see what you're saying. You'd like to integrate that, which it does make sense.
So I can do that. You're correct. But pharmacists on the front lines are walking around giving immunizations, checking PMPs, doing consultations. So I think it becomes a little bit challenging for them to then go that route every single time they fill a prescription. Because I think what you're saying is, wouldn't the pharmacist check the board's website first before filling a prescription? Do I have that correct?
Yeah, so I have some mechanism to do that, but I see what you're saying. The integration would probably be the best way. I do understand that there's a time commitment to doing that, and maybe not feasible, but I just want it to be clear that information is there.
Yeah, I think the challenge for pharmacists is that they count on their own pharmacy software system to stay up to date. And for big chains, that's not a problem. They're usually connected to something like LexisNexis or some type of data source. But your smaller independent pharmacies, they probably don't have that ability to do on a regular basis.
Yeah, and I was just kind of surprised to hear that you're taking verbal or written information from various prescribers saying don't fill this this type of drug if you receive a prescription from me. How does a pharmacist even track that? I mean, how are you putting that information in?
That information is never going. There's no place in the PMP to say do not do this. What there is an announcement field. And again, I put that out through like verbal writing. And again, you're hoping that everybody reads it when they see it. That's why I said it's far from perfect.
Right. So Doug, when the board does revoke or issues an order that a physician can no longer prescribe, we do issue an alert, and we do send it to the pharmacy board. Is that noted in that information section?
What happens is we deactivate their account, their PMP account, because that's what our focus is at the PMP, is making sure that you have access when you have the statutory responsibility to. But if you lose your license or you lose your DEA license, now you don't meet the statutory requirement to have access to the PMP. I think what you're asking is, do we have a great way to get that information out to pharmacists? And we take all those names of prescribers that you give us, and Kim includes that into a newsletter that goes out quarterly. There is no mechanism to where all pharmacists go to this one spot and you're going to know that this prescriber has had a certain action on their license. So we communicate it through a newsletter, which goes out through NABP, National Associations of Boards of Pharmacy. We share that information with other states, so they have that information too. So it's something, but it's not perfect.
Well, thank you for providing me with that understanding. That's definitely a benefit from this meeting, is finding out how the mechanics of things work behind the scenes that we may not be familiar with.
Awesome. I think that was an awesome question. Anybody else have any questions? All right. Sorry, guys, my mic powered off, so I'm switching. The next topic I wanted to hit on is our gateway integrations. And I do this every year during the task force meeting. Gateway is the integration of a PMP, the PMP to electronic health records of an organization, or in the pharmacy's case, your pharmacy software system. So the idea with Gateway is, with a click of a button, you can be in your own workflow within your organization. Click a button and it'll take you directly to the patient's PMP report. So it makes it a lot easier to get a PMP report in front of you, saving time in your work day, being able to check the PMP within your workflow at the time that's most meaningful for you as a practitioner or pharmacist. We've been doing this since about 2017. And we've made strides every year at getting more and more healthcare entities, more and more pharmacies integrated with the PMP. And but we're kind of at a plateau right now. I think what's driving that is our big entities went after it and got integrated right away. And that became a lot of heads that counted, So if Banner has 2,000 prescribers, well, 2,000 prescribers now have access to the PMP through Gateway, which is, again, that integrated way of accessing the PMP. As you get to the smaller entities, sometimes there could be some cost to the entity to upgrade their own software. Just to be clear, the Board of Pharmacy pays for Gateway. We pay for Gateway through some funds that we receive with the help of Department of Health. That Gateway access is truthfully the reason we have more and more and more queries of the PMP every year. It's just easier. But the smaller entities, there's a potential that there's a few holdups on why they're not getting across the finish line. But in your packet, I bulleted out a few of the potential roadblocks, and there's a process where terms and conditions need to be signed with the Board of Pharmacy. I think the smaller entities just potentially struggle to keep up with the communication, knowing what they need to do. and that could be a roadblock. The cost that they may have to incur updating their own software so that their software can talk to the PMP. That might be a burden. Their vendor may not truly participate in this type of activity. So, all the big vendors, we've been able to connect to your Cerners and your Epics and your eClinical Works, and the list goes on and on. I think there's about 80 different vendors that we're connected to. Don't quote me on that part, but there's a lot of EHR vendors out there, and they have a role in getting established with the PMP also. So those are some of the roadblocks that may be out there. So what do we do? Well, number one, if somebody has reached out to us having interest in integrating, but they never got their terms and conditions back to us, well, we reach out to them. We see if there's some type of miscommunication or not having an understanding of what they need to do. And then from the vendor standpoint, I think last legislative session or maybe 2 sessions ago, legislators said that vendors have to connect to the PMP by 2026. So if the hindrance is occurring as a result of a vendor, in due time, all vendors are going to be required to be connected to the PMP in Arizona, which means maybe some of those vendors that are not set up right now, they will be set up in the future. So I think that's really what I wanted to hit on. I know the integration can be a little bit confusing. I know that Melissa understands it very well. But I want to open it up for questions. I think the takeaway right now is about 68% of our providers in Arizona have the ability to access the PMP by clicking a button. And that's referred to as integration. Our integration is done through the gateway. Is there questions I can answer about that?
Hey, it's Bill Thompson. Oh,
Yeah.
sorry. Go right ahead. Whoever just started to speak. I'll go second.
No, I'm gonna let you talk, Dr. Thompson. I'm tired of talking.
No, I think, as you hit on the points, the integration is the holy grail for getting people to access the system. It made my life, because I check it more often than most as a pain doctor, much easier when I train new people to our practice, which is a large orthopedic practice encompassing non-pain providers. I train everyone to click the button every time. I think it's easy. It's built in. It is just a habit to get into. So I think the fact that you've partnered with the major vendors is a huge step. And I guess the question would be, because I don't know some of the background mechanics, is there a way to make it an opt-out instead of an opt-in system with the major vendors? Because you're hitting the vast majority of practices with increasing consolidation. There's very few EHRs that most providers are using if you're going to get the vast majority of them. And is there any way to remove the steps and make it a part of the vendor-specific product that they're offering in the state? Does that question make sense?
Your question does make sense to me. I think what makes it hard for regulatory agencies is there's not a law that's being broken. So, I think in a way it would be almost where, and this is just my 2 cents, where the ask would be you'd have to put into law to force entities to react to that. And I don't think anybody wants one more law on this. But I don't know how regulatory boards, I'm using the pharmacy board as an example. How do I force somebody to do that when there's no law that they're breaking? Argue with me, please.
No, I agree. And I don't, I'm remiss to try and add more laws and more regulation, et cetera. This is obviously best best practice, and are there regulatory or rules-based barriers that could be addressed to make it easier for that integration to just be automatic? I mean, this is where we're moving. The HIE has really profoundly changed point of care medicine, the ability to access records from other systems, et cetera. And I have a particularly good EHR, in my opinion, which I'm actually saying in a public forum. So that says something, because I hate most all of them. But, I think that, making it more the default as opposed to an opt-in, are there ways to work with the vendors to make it a part of their standard agreement process when someone signs up to use their services, that they check all these boxes and hit all the compliance hurdles so that it can be built in from day one?
So I think from a vendor standpoint in 2026, I think that at that point, they're going to be required to be connected to the PMP. And then the default really lies on the healthcare entity to say, our prescribers, our pharmacists have to click a button before they can move forward, before filling a prescription, or before the next step of, I don't know, your EPCS allows you to write a prescription, something like that. I think it's going to fall on, number one, we need all vendors connected. Or number two, we got Melissa on the call, and the HIE is connected. So for those that aren't connected based on their own electronic health records, EHR vendors, you can access the PMP through the HIE also, and the HIE is connected. It's integrated with the PMP. So I still don't think I answered your question the best way, but I think it's great conversation for us to keep bringing to the table, because every year we get closer to 2026, we know that the vendors have to be connected at that point. What's going to be challenging? What's going to be challenging on me is I don't even have a master list of all EHR vendors. So how do I know who's connected and who isn't? That's not anybody else's problem, but just things, food for thought as we get closer to 2026. Go ahead, Melissa.
I was just going to add in, I think it's a really good point. I was just going to comment to Dr. Thompson's question as to some of the barriers that make it tough for EHR vendors to have it automatically integrated. I mean, I think it's awesome that there's a state requirement for integration. So like you said, by 2026, it'll be a requirement. But a lot of times vendors look to state policy to actually drive what they're going to prioritize in terms of functionality. And it's not, unfortunately, the way the technology industry works, it's not in the vendor's best interest to bake all these things in, because these are upsell opportunities on their side, and they are going to want to, they're either going to have to like bake it into their core service offering, and then their cost is going to go up to all practices, which might be eventually what they do in 2026 and beyond. But right now, especially if there's different requirements in different states, then they will rely on state policy and requirements like the one that is in place for 2026 to be what they evolve to, because they're going to want to, frankly, upsell that connection to the PMP. And some of them, frankly, just don't have the technical sophistication to do the interfaces. I mean, that's the unfortunate reality, is that, like you said, you've gotten all the big ones to do it because they have this requirement in multiple states, and Arizona uses a vendor that is for PMP that's used across most states in the country. So they're able to bake it in. But I think you will have challenges getting the smaller EHR vendors, because they either just haven't done it, or it's not their highest priority. And a lot of times it's the squeaky wheel that gets the grease. So it's how many times their clients and their customers are requesting it, what their market share is in Arizona versus other states, and how this ranks on the list of priorities. The only other thing I could suggest is, hopefully as this continues to evolve, what would really be helpful, and this is kind of outside the scope of this task force, but it is from like a national policy perspective, is that these types of standards get baked into national technology certification requirements, so that you can have it more automated. Like, this is a functionality that your system must come with when you buy it off the shelf. So I just wanted to comment on some of the challenges because these are the same things that we see when we try and integrate smaller and less maybe robust or less used EHR systems, even to the HIE is very similar issues that, you know, the smaller ones are just harder to connect for a variety of reasons. I would also note, yes, we are continue to be happy to connect folks via the HIE, and we have that functionality. But because this integration effort has been so successful, which is great because it's integrated into the EHRs, we have very low utilization numbers of utilizers of the HIE who actually use our system to connect into the PMP. And I think that's actually a factor of the success of the integration effort. And certainly if others want to use that, we can provide that and we can discuss that. But I think the integration effort, statewide integration effort, has been very successful. So I think it's always best if you can keep things in workflow. And there are some limitations of, you know, being able for us to be a pass-through to keep it in people's workflow. So I think in the grand scheme of things, the direct one-click access from an EHR for CSPMP functionality specifically, based on how the system's designed, is best. But we still stand, of course, ready to support however we can. And if it comes to this point and we've still got a gap in who's able to easily access it, if they're already an HIE user, we could support that.
Melissa, thank you so much. I know you know your whole world it encompasses this, and she's my go-to person whenever I need to learn a little bit more, because I feel like I have a 30,000 foot view, but when we get into the weeds on this type stuff, I always appreciate your knowledge and your ability to share that in a meaningful way. Any questions for Melissa? All right. Well, thank you. Thank you, Melissa. Moving through our agenda, the next topic is our CSPMP education and outreach efforts. You know, so we work really hard to try to educate anybody that wants to be educated about the PMP, and that includes new prescribers, new pharmacists. Law enforcement has access to the PMP when they have subpoenas for the DEA or for the sake of the Attorney General's office if they have a warrant. These are like the education that we do. It's very different depending on who our audience is. What a prescriber wants to know is different than what law enforcement wants to know. And then this year we wanted to extend efforts to our licensing boards too, because in the past couple of years, licensing boards have been able to access the PMP for their investigations on their own. There was a point in time where they had to always request the data from us and we'd supply it to them. So with some legislative changes, our licensing boards now have access to PMP data, but we wanted to try to help them use it more efficiently. They're busy just like everyone else. So what we did this year was we had a few of our license boards come over, work one-on-one with my team, and just to understand how to use the queries and what the data is telling them. That doesn't mean that we quit communicating with licensing boards. It just means we know that any help we can give to use the PMP more efficiently and understanding the data is value added to those licensing boards. So this past year, we had the dental board, the nursing board, and the medical board all come over and learn a little bit from my team. I think I spent maybe an hour and a half with my team and got some quick tips, if you will, about the PMP. In addition, we try to hit new prescribers early in their career. So from hospital organizations, the hospitals will take on new residents every year. And what we do is we send Lynn out. Lynn kind of is our marketer of education. And we go there during the residents' first week at a new facility. And those facilities will give Lynn an hour at a time. He helps those new prescribers get registered for the PMP. He helps them understand what they're looking at with the PMP, very much like we do with the licensing boards. Just trying to get them started right from the start of using the PMP and understanding what the laws say around the use of the PMP. So we're proud of that. I think this past year we had 2 webinars that were attended by 200 residents and fellows from Banner and Dignity. Additionally, Lynn did an in-person registration event and Q&A at Barrows Neurological, St. Joe's Hospital, 50 participants. So what we do is we just really want to get out in the public, and we want to catch the prescribing community right off the bat. I put a little bit of information about that in your packet. Do you guys have any questions about what we did from a resident standpoint? There's even a one-pager there that we leave them with, just helping them get registered properly. And if you notice in that one-pager, there's a place for specialty. And that, if you notice, that specialty is self-reported. Why that becomes important is we send out quarterly prescriber reports, right? And sometimes our prescribing community has said you're comparing an apple to an orange because I am more pain oriented, or I'm more it doesn't really matter, but you wouldn't want to compare Dr. Thompson to an OBGYN on their prescribing patterns, right? You'd want to be comparing an apple to an apple. But the only way your specialty is self-reported. So if you don't take the time to pick your right specialty because you're just trying to get registered with the PMP, you have the potential to be compared to the wrong group. And then that gets frustrating down the road. I talked about the prescriber report there very briefly. Prescriber reports are not shared with anyone other than the prescriber themselves. Nobody else gets that prescriber report. The whole idea of the prescriber report is let you compare yourself to your peers and then make adjustments if you feel you need to. It's not the Board of Pharmacy's job to say you're writing too much, too little. That's not our purpose with prescriber reports. I know I just kind of veered off a tiny bit, but prescriber reports are intended for prescribers to look at and self-reflect on it and make any adjustments if they feel that it's appropriate. But that one pager has that field, and that's really important that the prescriber takes a minute and picks a specialty that is going to correlate with what they do every day. That's really what I wanted to highlight about the one pager, which is called the tips for residents, and that's what we give them whenever we get out there in these hospitals on the residents' first week. Probably what I'm most proud about is so far this year we've done 3 webinars, and the webinars pretty much the exact same every time. And that webinar is geared towards prescribers. And the things that we cover in those webinars are different reports that can be generated. And one of those reports we call the MyRx report. The MyRx report lets prescribers look and see every prescription that has been dispensed in the state of Arizona with their DEA number. So, for those licensing boards out there, that shouting that out to your license holders that there is a MyRx report, and that MyRx report, if you check it once a month and you look and see, do I see any patients on here that I don't recognize? Do I see drugs on my MyRx report that I don't write for, using Promet with codeine as an example? If you see those things, you should do a deep dive into what's going on here. And that might lead you to send communication to the board of pharmacy or your own licensing board. But that MyRx report is really a valuable tool to prescribers, because it's their DEA number. They need to protect it. And the best way they can protect it is look at their MyRx report for anything that looks bogus on there. We also cover the prescriber report that I was just talking about. We talk about the prescriber activity report, and that prescriber activity report is where a prescriber can look and see all the queries of the PMP that they've performed. And that becomes valuable just to know, are you really using it as much as you think you are? We also hit on integration. We let them know that, we let the residents know that it is possible to be integrated. Typically at these hospitals that they're starting with, those hospitals are already integrated. But you never know if they go into private practice afterwards. And if they go into private practice, we want them to know that they can integrate their practice. And then we hit on the fact that you can query other PMPs from, like, the PMPs of other states. And we also hit on a couple things with, like, delegates. If they're not integrated, you can have a delegate to query the PMP for you, and you'll still get credit as long as your delegate selects you whenever they use the PMP, because a delegate can be a delegate for more than one practitioner. So when that delegate is conducting a query for the prescriber, the delegate needs to pick the name of the practitioner that they're querying for. So that sometimes is missed, and we go over that and the importance of making sure you do that. I know you guys have all this material, so I'm not going to read line by line, but we've done this 3 different times, and our game plan is to do this every 2 to 3 months. It'll be up on our board website. We'll communicate with the other licensing boards and associations whenever we're going to be doing it. And the more word we get out there with the help of all of you, the more attendance we're going to have, and the more we get to shout out the value of the PMP. That's really what I wanted to highlight about our education efforts. I imagine there may be questions or concerns about some of what I just talked about, so I'm going to open it back up to the task force. Nothing? Well, if I have no comments on that, I think we all know that education is the key to anything new. And although the PMP is not new, the requirements are relatively new to use the PMP, and that's 2017. So that's not exactly new, but we continue to educate. I think what we'll do right now, if it's okay, could we take maybe a 5-minute break and then we'll wrap up and hit the last few things on the agenda. So Lynn, let's have everyone come back in 5 minutes. Welcome back, everyone. With a quick break in public meeting laws, we're going to do a real quick roll call again, okay? Ms. Walmsley?
Present.
Oh, I hope I don't butcher this one. You told me how to say it. Ms. Scheinsen?
You got it.
Thank you.
Present.
Ms. Romero?
Present.
Dr. Villarreal?
Present.
Dr. Thompson?
Present.
Ms. Samudo?
Present.
Mr. Bohal?
Present.
Ms. Fine?
Here.
Thank you. How about Miss Wingert? Did she show up?
Present.
All right. Welcome.
Thanks.
Mr. Williams,
Present.
Miss Cochise,
Present.
Miss Almer, Miss McSorley,
Present.
Miss Steffen,
Present.
Miss Berman,
Present.
and Miss Bukta. Vicky, you out there? We'll check again a little bit. So we still have a quorum, so I'm going to keep moving along here. The next segment is really around our compliance efforts. And, you know, when you think of compliance with the PMP, there's a few different buckets that you really think about. You think about our data submitters submitting every day. And that's really, you know, where our pharmacies are reporting in what they need to every day. And then you also think about pharmacists are required to check the PMP. You think about prescribers need to be registered to use the PMP. Prescribers need to use the PMP. So there's a few different buckets of compliance that we're monitoring, and we're going to talk about that. I'm going to hit on what we're doing around the pharmacists and some of the challenges we have with pharmacists compliance with PMP. And then Jenica is one of my team members that works heavily with our compliance efforts, and we're going to let her tell a little bit about what we're doing there. So where I'm at on our little book of information I gave you is on page 11, and we're going to dive into pharmacist registration enforcement. And obviously, if you're not registered to use the PMP, you can't use the PMP. But the law says you need to use the PMP. So if you're not registered, we got a problem. We started measuring pharmacist compliance in 2021. We do a really a good job of that, and we go after an educational approach with everybody first. Doctors, pharmacists, it doesn't matter. We want to make this where we're helping you do what the law wants you to do. And by taking that helping approach, what we do is if we'll reach out to pharmacists that aren't registered, and we'll help them. We'll walk them through step by step. Let's get you registered. Now, if we can't reach them or they don't want the help that we're offering, then we take action. So between November of 2021 and June of 2023, there were 1,100 pharmacists that we helped get registered with the PMP. We've had very few cases that we opened up because through our efforts of reaching out, we've been able to get people registered with the PMP. usage of the PMP and measuring that usage, it's a son of a gun. When you think about what a prescriber, the difference between measuring prescriber usage and pharmacist usage is when a prescriber writes a prescription, they have their DEA number on that prescription. And it's easy to tie that prescription to a individual prescriber that should be checking the PMP, because that information is submitted through the data that gets submitted to the PMP every day. With pharmacists, it's hard to tie a specific pharmacist to a requirement to check the PMP, because we don't know which pharmacist is responsible for checking the PMP within the workflow of the pharmacy. And when you talk about mail order pharmacies and shared service pharmacies, it gets more and more convoluted on who's supposed to be responsible for checking the PMP. And the only way I can tie a individual prescription to a lookup of the PMP, it requires some identifier of that pharmacist to be transmitted to the PMP during the daily data submissions that the pharmacies do. That individual identifier could be like a pharmacist license number. It could be also an MPI number if we wanted. Either of those things would be an identifier that would enable us to be able to cross-reference and say, the person that should have done a query on a certain prescription from a pharmacy standpoint would be, Doug Scavarla. And we know it's Doug Scavarla's responsibility because of the data that was submitted to the PMP. Last year, we talked about this during this meeting. This group called for a subtask force group to be created. We had that meeting last year. The subtask force unanimously decided that they felt like it would be a burden on the pharmacists, the pharmacies, to report that additional data into the PMP. So at that point, I still can't tie any one prescription to a query of the PMP. And until we change that, that's just going to be impossible to do. So what have we done? Well, we've went after educating again. We keep talking about education, and when our compliance officers do inspections, we have a one-pager reminding our pharmacists about the laws of checking the PMP. Again, we do educational efforts every which possible way to try to keep our pharmacists abreast of the fact that they need to check the PMP. Dr. Gandhi, do you have anything that you'd like to add on this section?
I think Doug, yourself and I have repeatedly talked about this subject, and it's becoming a bigger and bigger challenge as how do we effectively track the use of PMP by pharmacists. And today we're leveraging compliance officers and your staff creating, almost moving backwards when we have the technology and the resources to be more effective. And one of the challenges I think we've talked about also is that we not only license pharmacists in this state, we may license pharmacists in other states and other jurisdictions. And if they're working for a permitted facility, they don't need an Arizona license. They can work off that permitted facility, which means our formatting of our license numbers may be different than other states' formatting. And that becomes a problem when we're trying to track using license numbers. So I think yourself in discussion with me, though we're trying to get creative on how to better track, we keep coming to the end road of NPI would be the best option, no matter how many different scenarios we discuss and we contemplate and so forth. this discussion is not new. I think it's happening across the country, but I think we're approaching a crossroads in our state faster than other states are. And I think at some point we're going to have to make a decision on how to better track these individuals.
Thank you. Yeah, I think when you talk about an MPI number being the identifier, not all pharmacists have NPI numbers. Most do, but not all do. And then even if somehow we were requiring all pharmacists to have NPI numbers, would all states require them to have an NPI number? And it seems like some hurdles to get over, but I agree with you. I'd like to be able to track this better. But without the data coming in through the data submitters, it's just not possible. I know I got a little technical there. Do you guys have any questions on why that's a hurdle for us? The short of it is data submitted to the PMP through something referred to as ASAP standards. ASAP standards has a field that can collect an identifier for a pharmacist. If that field was populated and submitted to the PMP, I could tie a prescription to an individual pharmacist, and then I can measure compliance around that. But there's no law today that requires that to be submitted. And the subcommittee task force from last year voted against doing that, so we did not.
Doug, this is Lori. Just, I guess, to further add, you mentioned mail order pharmacies. I do think that is in particular a big challenge for us, since we have so many mail order pharmacies in the state of Arizona, and those pharmacies are filling prescriptions oftentimes for people that aren't even located in Arizona. So checking the PMP data in Arizona really wouldn't do them any good. They would need to be checking it in the state where the patient resides. So in that particular case, you're actually creating additional administrative burdens for something that doesn't even really make clinical sense. So I agree. I would like to find a way that we can do this. The challenge is that it's the dispensing of a prescription is so much different than the writing of a prescription, and it's typically not necessarily even tied to one single entity. So who's responsible for that portion of the prescription? Is it the pharmacist that checks the DUR? Is it the pharmacist that checks the data? Is it the pharmacist that counsels? And I think every different pharmacy's workflow probably has it done in a different place, and perhaps there's even multiple pharmacists that are looking at it. So I do think it's important, but the workflows that exist in all kinds of pharmacies, I think, can make it very problematic for us.
Without a doubt, it would require a lot more language to law, and that could be challenging in itself. Not only will we need a requirement to report, but to your point, how are we defining who is the responsible pharmacist, right? Because by having that empty field or having that field populated, the pharmacy would need to know which pharmacist credentials go in there, which license number or NPI number. And that really gets tricky whenever a prescription could be typed in Ohio and the directions and interactions could be reviewed in Florida, and the drug is actually filled in Minnesota and the patient is in Arizona. It gets really convoluted. So there's a lot to work through. Yes, and I think we'll probably continue to bring this up and look for solutions, but it is a very difficult solution to get to the bottom of. I'm going to move on then to the reporting, CSPMP reporting. And you know, that's the most important thing here is that we need the right data in the PMP. And the only way data comes into the PMP is through the pharmacies that are filling these prescriptions. So I know many of you on this call have encountered somebody that's saying, I don't see something in the PMP that I was expecting to see in the PMP. And that's usually a data submission issue. And so we take that serious. We have reports we run, and we go after delinquent data submitters. Something that is noteworthy is in Arizona, you have to report daily, even if you dispense zero. We have what's called zero reporting in Arizona. So for anybody out there listening, you know, if you're part of data submissions at a pharmacy, you want to make sure you're doing your zero submissions every day. Otherwise, you're going to populate our non-compliance report. We've sent a total of 234 notices regarding delinquent reporting. Most of those, again, we're able to help them. Sometimes it's a vendor issue. Sometimes they don't know that their data submissions just aren't reaching us. So we've been able to help all but 8 of those get things straight, get on the right track. We've opened 8 complaints at the Board of Pharmacy on pharmacies that were delinquent in their reporting. And we'll continue to do this. We're you know, without the right data in the PMP, healthcare providers cannot make the right decision. So we take this very seriously. And then the next segment is prescriber compliance. And again, there's prescriber registration, there's prescriber use of the PMP. And I'm going to turn this over to Jenica and let my voice rest a little bit.
Good morning, task force members. My name is Jenica Brown. I'm the compliance manager for the CSPMP. I'm going to walk you through our prescriber registration and usage communication to the licensing boards. Where reporting enforcement is the heaviest lift from an investigative standpoint for the CSPMP, prescriber registration is without a doubt the heaviest lift for the licensing boards. In 2022, we sent 7,055 names to the regulatory boards in Arizona. And as of July of this year, we've sent 6,555, which is down 7.09% from the last year. Twice a year, we send these reports over with the names of prescribers who are required to be registered with the CSPMP. And we send those reports to the respective licensing boards. Our data analyst obtains these names by comparing DEA data with active DEA numbers in the CSPMP. DEA numbers that aren't linked to an account are identified as not registered, and those names are sent over to the licensing boards for further review. There are a couple of hurdles to consider, which we do our best to communicate to the licensing boards, such as prescribers having multiple DEA numbers, but not having all of them linked to their account. We try to take a proactive approach to limit this issue by sending out an announcement through Aware to remind those who are already registered to add in any other active DEA numbers to their accounts so that they don't appear as if they're not registered. Sometimes there are also prescribers who populate on the list with active DEA numbers, but they aren't licensed in Arizona and they're working at a federal facility. If they don't have an Arizona license, they aren't required to be registered in the Arizona PMP. There's also a possibility that a prescriber's DEA status could change from the time that they are identified as non-compliant and the time that they are contacted by their licensing board. Again, if a prescriber doesn't have an active DEA number or an active Arizona license, they aren't required to register. Overall, we've seen a significant increase in our registration numbers since November 2021, 9,750 new registrations were processed and these prescribers now have access to the CSPMP. This results in an increase of 25.77%. Within the reference material, the licensing boards can find statistics specific to each board regarding their unregistered prescribers. Moving to page 15 of the reference material, we'll cover prescriber usage. Not only prescribers need to be registered, but they also need to use the CSPMP. Arizona Revised Statute 36-2606 states that before prescribing an opioid or benzodiazepine in Schedule 2 through 4, a medical practitioner must obtain a patient report for the preceding 12 months. Our data analysts are able to identify prescribers who have not completed any queries in the CSPMP, but have written for opioids or benzodiazepines. The CSPMP sends the top 10 non-compliant prescribers to their respective licensing boards for further review. Moving forward into 2024, we will begin sending the top 20 non-compliant prescribers. Lynn, if you could please pull up page 15 of the reference material. Oh, thank you. This chart shows the number of reports sent out to licensing boards from June 2021 to June 2023. We'll revisit this piece of compliance to solicit some feedback from licensing boards regarding these reports. Before I pass the baton back to Doug to go over that, I'd like to open the floor to any questions.
Jenica, within our packet, we included some information about providers that do have multiple DEA numbers, right? Is that information something that would be helpful for other licensing boards to distribute at their discretion, or is that how do we get that information out the best way possible?
Right now, we are sending announcements prior to running an audit of the DEA numbers in the system. However, on page 16 of the reference material, you'll see exactly what's sent out to the prescribers who are already registered with the CSPMP. I think that this information would be very useful for licensing boards to disseminate as they see fit. It gives really detailed instructions on how a prescriber can add additional DEA numbers to their account to avoid being added to the list of non-compliant prescribers.
Thank you.
Excuse me, this is Josephine from the Arizona Osteopathic Medical Association. I just have a quick question. This information that is in the packet that you provided to us, is there a link to it on the site so that if we were to help the licensing board in getting the word out, we could include a link to this, or do we have to recreate this prescriber registration information that you've provided in this packet?
I don't think we have a link up right now, but Josephine, I think that's something that we should do on our end, and we'll get a link created in the next week, and I'll distribute that link to this group.
Thank you. I think that would be helpful. At least we can do our part in helping the boards get the word out.
Yeah, the prescribers that have multiple DEAs has been kind of the nightmare on licensing boards, because we've provided DEA numbers that are not registered because we get that data from the DEA file. What we don't know is, who has 4, 5, 6 DEA numbers, and then we end up sending that information to the licensing board, and the licensing board hears from the prescriber and says, no, I got an account and I check the PMP every time. And sometimes that's literally true. It's just that they haven't registered those additional DEA numbers with the PMP. So it appears like they're not registered with the PMP. So I think that'd be helpful, and we'll do our part. We'll get that information out to everyone. Any other questions about our compliance efforts? I'd like to give you guys as much time because, way back when I started in this role in 2017, it was the PMP will not be punitive. We're just educational. And then laws got written to say you had to use and you had to check and you have to be registered. And as those laws came about, I've been challenged with upholding those statutes. And so we're trying to do it in the gentlest of ways, but at the same time, if we're not getting any reaction, then we're given the information to appropriate licensing boards. Okay. Well, then I guess we can move along. Page 17. Pat and I had a discussion earlier in this meeting, and we were talking about like a licensing board integrations, and we're in the process of a potential vendor change from our pharmacy software system, which is different than the PMP software system. And what we're trying to do is when we get that set up, where we're integrating those two platforms together so that I can pull all the pharmacists over and match it with PMP registrations to be able to identify non-compliance at all times. I'm going to keep my fingers and toes crossed that this actually happens. And if it does, I would hope that would happen in the earlier part of 2024. And if we can make that happen for the Board of Pharmacy, we can also potentially integrate other licensing boards too. And that's what Pat and I were talking about. Even though that wasn't really Pat's question, I brought up that we potentially could integrate other licensing boards information with the PMP, enabling us to really do a better job at measuring compliance at all times, not just once a year. So that's more of like the pie in the sky that I'm hoping for, but I want to let the task force know that that's something we're chasing. I'm not going to knock on anybody's door on integration until I get it right with the Board of Pharmacy. But if we make that integration work for us, it might be able to work for other licensing boards too. So more to come. It was just more of an FYI I thought I'd put into the packet and let you know, because we don't meet on a regular basis. I thought just letting you know that may come in the future would be helpful to you. And the last section I had was, we've talked a lot about our compliance efforts. We've talked about the fact that we're communicating with other licensing boards, and we've had them come in and get some tips. We've had a lot of exchanges, learnings both ways. And I thought it would be a great idea to get feedback from the other licensing boards on how we doing with it. Tell us what we can do better. Tell us what you like. Help me understand, how I can make your job easier with the information that we're providing. So I hope I don't get silence here, because I'd love the feedback.
Hey, Doug, this is Raquel with the medical board.
Hi, Raquel. Thank you.
Hi, everybody. So thank you for going over everything. Pat had questions on the same things I did. I think our big beast is the individual provider non-compliance. Well, the non-registration with the CSPMP, just because we have the largest pool of licensees. And the multiple DEA thing comes into effect, and the different licenses and their statuses. So we continue to work on that, and I continue to brainstorm different ways we can go about it. But I do appreciate and like the individual reports we get with the provider non-compliance. It specifies the dates for us. It gives us, a place to start our investigation. And then based on the trends we see in the PMP, we're determining whether we do chart reviews to look deeper into the prescribing habits of the provider instead of just focusing solely on the non-compliance. And so I think we've gotten really good outcomes from our investigations on the cases where we can educate doctors. We let them know, hey, your registration's not correct, or you're not associating this delegate, you're not getting credit. We're seeing doctors change their practice so that they are copying the CSPMP reports and including them in their records just as extra due diligence in case there are questions about the query later. So I do think a lot of good things are coming. It's just a matter of playing catch up with some of the old school doctors who may have misunderstood the requirements of the statute, or they're just checking it once, or they're not checking it quarterly. So there's a lot of education that's going on during the investigation process itself too. The dispensing non-compliance reports were new for us within the last few months. And so my staff did recognize it was a new type of case, but we reached out to your staff and really understood what it is that we were looking at. And I think in those cases, we were able to get the right contact information for the doctor that maybe you guys didn't have. So I would just say, in the future, if you guys are having issues reaching our licensees, feel free to reach out to me, because we may have more updated information on their end from what you guys have. From if it's from their DEA or something else, and we can probably close that gap sooner rather than creating a whole investigation. So that's just how we're working through these different things right now.
Fantastic feedback for us, and I know you met with my team and talked about that in particular, and that's the type of feedback I really love, because it's work on my staff, it's work on your staff, and we're all trying to do the right thing. And if there's ways to make it better, I think you just came up with one, and that's fantastic. Thank you.
Yes, thank you all for your efforts. I appreciate it.
By any of the other boards, anybody have anything that they'd like to share? Good, bad, ugly? I don't care. The feedback that you give me is gonna help. I know that. All right. Oh, go ahead. I heard somebody.
That's me. It's Justin from the Osteopathic Board. I guess one thing that could kind of help us in the notice that you send regarding compliance, if you could also indicate on there if you've previously sent us a notice about them, or if you've sent us them in their list of unregistered PMP providers. We've been trying to make sure that we have that information, but if that's something that you readily have when sending that notice, that helps us escalate the investigation process with that provider.
Yeah, I think when we first started this, we were seeing names populate on reports every time, and the feedback that we received was, Doug, give us time to work on it before you give us second notice and third notice, and because you have your own workloads. I think what you just said there, Justin, is something we should talk about collectively right now, which is if if a prescriber populated the non-compliance report this month, and we're doing reports every month, and we're going after like what we're doing is we're taking the highest prescriber of benzos and opioids and 0 queries of the PMP. And these numbers are in the hundreds, over 100. So, we know that there is a need to check the PMP if you've written 100 benzos and opioids and 0 queries of the PMP. We furnished that in February to the licensing boards. Now it's March. We're running the same report. What I'm hearing you say, Justin, is please include that name again. Is that correct?
And maybe
otherwise it gets kind of gets lost in the shuffle. But at the same time, we're picking the top 10 top 10 prescribers of having a lot of prescriptions written and 0 queries of the PMP. So do I put that name on the list again, month after month after month? Is that the ask? I'm okay with either way. But when I first did that, I had pushback saying, I haven't even had a chance to work on it yet.
And I do appreciate that. I was kind of thinking more along the lines of if you've sent us notice about them before, an indication that maybe this is a second time offense, or they really should have cleaned up this behavior by now. It's been 6 months since the last notice, and this is a second notice about them.
I think that challenge I have is there's thousands of names on there.
Okay.
Not being registered.
I appreciate that. Thank you.
Yeah. So then I send you the and that's what's overwhelming for you guys too. And I totally get it. It's like I send you a list of non-registered that is maybe 1,000 to the osteo board. That list is changing month after month after month. And I can't really go back and say what's the difference between this month and last month.
Understood. Thank you.
Justin, this is Raquel speaking, and that's something that I've thought about too. Luckily, I don't think we've gotten notices after we fully investigated a provider that the conduct has continued. And during our investigation, what we're doing is we'll notice them, get their response, and then we'll ask the pharmacy board to pull any queries subsequent to the notice of the complaint. So subsequent to the time they were notified of the complaint, because at that point they became aware that their conduct was inappropriate. So then we'll start pulling the queries that they've done from that point forward, just so we can have some evidence of reported practice changes or not. And so that hasn't came back to bite me yet. So I think that we're delivering the message either through an advisory letter, if we are taking action, putting them on notice that we're tracking it. And we haven't got any other duplicative or continuous reports of noncompliance, but we are checking that compliance during our investigation before we close the case, just to confirm practice changes and that they are using it and it's consistent with the amount that they're prescribing.
Thank you, Raquel. That is a really great suggestion on going back and asking for a second report. I'm going to recommend that for my investigative team to do that. Thank you so much.
Yeah, and if you want, Justin, I can type out like a real just quick process on how we're working these, just if you want to take a look at it and take from it what you want.
That would be great. Thank you.
Mm-hmm.
Raquel, thanks again for sharing. And that was my hope, is that we'd stimulate some conversation about how we all help each other. And back to my question, what does work best for you guys? Regarding that fact that they could have populated February and March and April, and we're sitting there saying, well, we want to share more names of prescribers. And again, these are prescribers that have over 100 prescriptions and 0 queries. This isn't a witch hunt. This is just a neglecting to use the PMP. So we want to get these names in front of you. I don't, way back 2 years ago, it was what's going to be manageable to licensing boards, and Pat and me and we had a discussion about what can boards handle. So we came up with 10 to 20 names, and now those 10 to 20 names, they get divided up between the different licensing boards. So any one licensing board probably never sees more than about 8 at one time. Keeping your workload manageable and attacking the most egregious offender of not using the PMP. So once I've given a name to the licensing board, do you want me to continue to keep that name and send it month after month so it doesn't fall off the radar? Or is that kind of a nuisance to you because you're like, I haven't even had a chance to deal with last month's report?
This is Raquel speaking. Just from the medical board perspective, I think that it just creates more work for us to confirm that we're already reviewing that conduct in a previous investigation. I mean, we're tracking all investigations in real time as we open them. So we have a mechanism to see like, oh, the pharmacy board reported this last month. We're looking at it. I don't know if a monthly on your radar thing is necessary. But I would like to know like a year after you've reported me, because my investigation should be completed by then. And if I had practice changes in my investigation, but he's still showing up a year later, that's something that I would want to know.
So with you wanting to know that, you can have that information. Would it be fair for me to say, well, you asked me for it? Or do I need to like keep track of who I sent what to when?
That would be the hard part, because we wouldn't necessarily track. I mean, after we've taken an action, it's in the board system, but unless they're on probation, we wouldn't have a mechanism to keep them under compliance, to keep looking at them, I guess. So to say, to like have that reminder for us, like, hey, follow up on this guy. Because once we've taken the action, it's the action. So it does create maybe more work on your guys' end to follow up. But I wonder if there's like an internal mechanism, like if they showed up for more than 6 months after your initial report, if there's a way to, let us know at that point.
Let's see what we can do. I like where you're going, and maybe we'll schedule a meeting with you guys and see if we can brainstorm what works best for all of us.
Sounds good. And I'll bring it back to my team too, the ones that are, I mean, I'm working these, but they're working way more of them than me. So sometimes they have little brainstorming ideas. So I'll just get some thoughts too. So when we speak, I'm prepared with some ideas.
Awesome. Thank you so much.
Mm-hmm.
Anybody else have any comments from the licensing boards? That's all I have, guys. If there's no other questions, I think we're good. Lori, you have anything else you'd like to say?
Just thank you on behalf of the State Board of Pharmacy for the collaboration and the discussion. I think it's really important that we work together, and a lot of good best practice sharing, and just appreciate everybody's attention and participation today.
Awesome. Well, thanks everyone. I hope you all have a good rest of your day and a good rest of the week. Appreciate y'all being here.
Thank you for everything.
Thank you.
Thanks. Have a great day.
Bye-bye.
Thank you.